Assalamu alaikum. The clinical day, non-clinical consultation day. First scenario, Mr. Ali, 39 years old, a gentleman with a history of uncontrolled asthma symptoms despite treatment. Please take history, examine, and address all concerns. Dr. Wahi and Dr. Mayada, we can start in a second. So, sharing the timer. Here you go.
Hello, good morning. I'm Dr. Ismail, Senior House Officer in duty now. Am I talking to Mr. Ali and you are 39 years of age?
Yes, doctor.
Nice to meet you, Mr. Ali.
Nice to meet you.
Today we will discuss your health issue and I will examine you and address your concern. Is that okay with you?
Yes, doctor.
Initially, may I ask you, how can I help you today?
Yes, doctor. I've been coming to the hospital with this on and off. Every time I have this asthma symptom, and I want to know exactly. I do everything the doctors told me to do, and still I have this symptom. That's why I'm here.
I'm sorry for that, Mr. Ali, and I hope after I discuss with you today and I examine you, I will address your concern. You told me that you have asthma before?
Yeah, I've been diagnosed with asthma now. This is the 6th year. For 6 years, I've been diagnosed with asthma, and I'm taking the blue inhaler. And what I found out that it's not help. And also, I take another inhaler. I think it's steroid. They said to me. And despite this medication, my symptoms is still.
So may I ask you, Mr. Ali, you feel that symptoms deteriorated recently or since 6 years and you still have the symptoms and no relief on the medications?
Yeah, recently, yeah. Recently. It's increasing. I have the symptom before, but now it's become worse.
So your symptoms was controlled by the medication when you diagnosed as asthma since 6 years back. Is that right?
Yeah, it was.
Since how many time you feel that your symptom deteriorating and not responding to the medication?
I think mainly on the last year.
Last year.
Yeah.
Initially, Mr. Ali, may I ask you who diagnosed you that you have asthma? Who told you this? Who's the doctor?
Yeah, we're here in this hospital, in fact, and they've been
so
the hospital.
So lung doctor or GB?
The lung doctor.
Lung doctor. Did he do for you the blowing test?
Yes.
And the result is at that time showing that you have asthma.
Yeah.
Is that right?
Yes, you are right.
Okay. Mr. Ali, may I ask you, sorry to ask you this question. Are you compliant or adherent to your medication?
Yes. Yes, doctor.
Any changes in the dose, any drugs added recently?
Yeah, they changed the dose several times. Every time when I came to the hospital, they just increasing the dose, and they give me this steroids.
Adding new medications. Adding new medications.
Not recently, yeah, not recently.
Not recently increase the dose or medication?
They increased the dose, but they didn't add another medication.
Okay. Can I know what are these medication? Can you show me your medication list?
Yeah. So salbutamol, PRN, salbutamol, and corticosteroids.
Inhaler?
Yeah.
What else?
Prednisolone on attacks.
Oral. Okay. Any other medication?
No.
Okay, Mr. May I ask you, Mr. Ali, do you have any new job or you change location of your job?
No, not my job.
No changes. The same location for your job.
Yeah.
Do you have pets at your home?
Yeah, I have a cat, and this cat for a long time with me.
For a long time.
Mm.
Any exposure to any new media or environment?
Uh, in fact, yeah, I changed my house recently. Yeah, I changed the house
You
recently.
change your house.
Mhm.
So any exposure to any dusts, any new pollutions or any?
Uh, I keep my house clean, in fact.
But the environment outside the house.
No, it's okay. It's not nothing changed a lot. I think the same environment outside.
Okay,
Maybe.
okay. Uh, so now, Mr. Ali, may I ask you, do you notice that you have noisy chest by night?
Yes, I have wheeze.
Any wheeze, any cough?
Yes, I have cough.
Is this cough, it has phlegm?
Rarely, yeah. Sometimes I have phlegm and sometimes no.
What is this phlegm color?
Uh, white, whitish.
White. Any change in the color recently?
No,
Any blood come with this phlegm?
no.
Okay, okay. Do you have any chest pain?
With the cough, yeah, I feel chest tiredness.
Chest tightness. Okay. Do you have any recent infection?
Uh, Recent infection. Last time, you
Any,
mean?
any bug infection? Yes, any bug infection or repeated bug infection?
Yeah, I think last time I have viral infection. This is the last time when I've been admitted to the hospital. Yeah.
You admitted before.
Yes, I was like I was admitted 1 month ago.
Okay, okay, okay. Recently, you have any change in your body temperature?
Nowadays, no.
Before?
Before that's one that when I was admitted 1 month ago.
Uh, for how many times you have this repeated infection to your lung?
No, no, they said it's not in the lung. As I understand, that was like just in my nose because I have viral infection, but it's not like pneumonia kind of things. Do you understand what I mean? So this was that time, but otherwise, no. Even if I have no infection, still I have these symptoms, asthma symptoms.
I'm sorry for that, Mr. Ali. Do you have, may I ask you, do you have any weight changes?
No,
Any night sweats?
no,
Any lumps or bumps in your body?
no, as far as I know.
Any change in your bowel habit?
My bowel is okay.
Okay. Any difficult swallowing?
No, I'm okay.
Any feeling thick or throwing up?
No,
Any change in your water work?
no,
Amount, color? Any blood in your urine?
no, okay.
Okay. Do you feel any lumps or bumps in your body?
No,
Any changes in the figure of your nose? Do you feel that this figure depressed, uncrusting?
no.
Okay, okay. Do you have any shortness of breathing by night, getting
Yes.
up by night, searching for air?
Not exactly, but
How many pillows do you have
in fact,
by
I
night?
when I have these cough things and with the chest, I just sit up because I can't sleep with these symptoms.
Yeah, I'm sorry for that, Mr. Ali. Do you have any joint pain?
No joint, no,
Any skin rash? Any skin rash?
no.
Okay, okay, Mr. Ali. Sorry to ask you, Mr. Ali, do you have any, I will ask you this previous question. I usually ask this question to all my patients. Do you have any blood transfusion before?
No,
Any casual relationship?
no,
Mhm. Any piercing and shearing needles? Any recreational drugs?
no,
Okay. Any recent travel, Mr. Ali?
no,
Mhm. Do you, before you exposed to any chest patient or area endemic for the TB?
no, as far as I know, no.
Okay, Mr. Ali. May I examine you and I will continue questions during the examination?
Yeah,
Okay, I will start with examination of the, I will take a, general inspection for the patient, any toxicity, any cachexia, any changes like this, pallor, weakness, toxic. Is that right? If, appear in the patient? Huh?
no, no, nothing like that.
Okay, I will see the hand. There is any clubbing?
No,
Any pulmonary edema?
no,
I will ask him to extend his hands in front and the flexion of the wrist to see any flabby tremors, any respiratory failure,
no,
any fine tremors of the hand.
no.
What about the respiratory rate? How much?
Now his respiratory rate is normal. It's 20.
Any proximal myopathy?
No,
Any skin rash?
no,
I will see the eyes for any jaundice, any anemia, pallor,
no,
mouth for hygiene, for gingival hyperplasia, for like this.
no.
There
It's
is
okay.
no wasting of the muscles of the hand or or muscular guttering of the back of the dorsum of the hand. Is it anything?
No,
Okay, I will auscultate the chest for wheezes. There is wheeze?
scattered, scattered
Yes.
wheeze.
Any crackles?
No crackles.
Any bronchial breathing on the lung?
No,
Any area of diminished air entry?
no,
I will percuss there is any stony dullness or in the basal lungs fields. Okay, I will organomegaly. I see any liver, any spleen.
no.
Mr. Ali, do you have any past medical history other than this asthma?
Mainly asthma.
Mainly asthma. There is anything else?
No.
Okay, Mr. Ali. Do you smoke, Mr. Ali?
Yes, I smoke.
2 minutes.
How many cigarettes for how long?
Around 10 cigarettes for the past 4 years.
Okay, I'm sorry for Mr. Ali. You know that smoking is very injurious for the health and especially for the lungs. And I advise to stop smoking. And you, if you don't mind, I will refer you to the smoking cessation clinic. Is that okay with you?
Yeah, it's okay.
Do you drink alcohol, Mr. Ali?
Social.
Social. Anytime. What about weekend?
I just drink in occasions, on social occasions.
Mhm. No, any time that you drink it too much and they become fall down and lose your conscious level and
No,
the
no,
aspirate.
no,
No?
no.
Okay, Mr. Ali. Okay, I will examine the lymph nodes. There is any possibility of lymph nodes, axillary or cervical or supraclavicular?
No.
Okay, Mr. Ali. Okay. Do you have any headache, Mr. Ali?
No.
Any weakness?
No.
Any abnormal sensations?
No.
Do you have any shaking of your body?
No.
Okay, Mr. Ali. May I ask you, Mr. Ali, what is your concern?
Why my asthma is not controlled?
Your concern is valid, Mr. Ali. There are some possibilities in my mind. Actually, I will raise these symptoms to my senior, and I will discuss with him, and possibility will run for you some investigations for that what I thinking in. Then I will update you for the results of these investigations. But at the moment, I ask you to stop smoking because possibility that it can trigger this asthma. Okay?
Okay.
May I ask you, Mr. Ali, for in this new house, do you notice anything strange for you? Anything that can precipitate your asthma? Do you can you share me your thinking regarding this issue?
Unfortunately, she cannot share her thoughts because time is up.
Okay.
Sorry, Dr. Okay.
You know,
But you come at the end. This patient now he moved
Don't
to
help him. He said don't
okay.
help me. He said don't help me. So let's play it till
Now
the
he
end.
stop. The second
No,
stop.
no.
We
But the
stop
examiner,
here.
no, examiner. We want to face him with the examiner. Let's start the examiner question, Dr. Mahi.
Yes, now I take the clue. Yes, I remember now. This patient has sinusitis and there is post-nasal drip. Is that right, Mr. Ali?
No.
Huh?
No.
Okay. You insist to talk to the patient.
Okay, let's start the examiner
Yeah,
question.
start
Okay.
please. Very funny, Dr.
So
Mahi.
present your case.
This Mr. Ali, 39 years old. This patient diagnosed as bronchial asthma 6 years back, and despite he is on stable medications and he is adherent to this medication, he is still uncontrolled and he feel wheezy, and he exposed to recurrent attacks of cough and noisy chest by night. I search for any precipitating factor for that. He's still a smoker, and he changed his house to new house recently, but there is no any changes in the job or bits or from the positive finding in the history, he has chronic sinusitis and possibly post-nasal drip. I asked him for the GI symptoms such as GERD or throwing up, feeling thick, difficult swallowing like this. He denied any possibility of GERD.
Okay. What let you think about sinusitis?
Okay.
Why you said that the main possibility that he has sinusitis? What in his history that indicate that he has sinusitis?
He told me he has recurrent attacks of upper respiratory tract infection or viral, and he told me that he has nose, runny nose, and like this. So possibility he has nasal drip.
He have viral infection once. This is the time when he has been admitted to the hospital, but he has not recurrent infection.
Okay.
He have no recurrent infection, and he never said that he has runny
He
nose.
told me he has recurrent.
Once viral infection.
He told me he has recurrent infection. Okay.
I
No,
didn't talk.
okay. Because he already admitted to the hospital once.
Once, yeah, he was admitted to the hospital once. Was diagnosed with viral infection. That's why he has been admitted to the hospital, but he has no recurrent of viral infection. He never said
Okay,
that.
where is this viral infection? Where is this viral infection? In the lung or where?
Upper respiratory
I
tract.
don't know. Upper respiratory tract infection, so not bronchiolitis. So less likely to be. Okay, doctor.
So what's your differential diagnosis? Why this patient has asthma symptoms uncontrolled? anything from the history you've taken indicate why?
From the history,
Mm.
possibly smoking, one of the triggers, new housing and environmental pollution.
Okay.
Maybe he has atypical infection in his lung. He has cough and sometimes whitish sputum.
Okay. Okay.
Maybe those medications are يعني sub-dose. Only he has salbutamol, but possibly we should add for him corticosteroid inhaler. So the
He's
medication are less.
salbutamol and fludrocortisone. He's already on
He
board.
has only prednisolone. He has
Cortico
prednisolone oral during the acute
during
attacks,
attack
but
and
we
fludrocortisone
should add for him.
in cortisol inhaler.
He
Yeah.
has a cortisone inhaler.
Yeah.
Okay, so possibly increase the dose. We should increase the dose. Okay.
Okay. What you will do for this patient? What is your management plan?
Management plan. I will do for this patient chest X-ray, high resolution CT.
Why chest?
And
What are say the investigation and what you're looking for?
Yes, I will do for him chest X-ray, high resolution CT to rule out TB or any atypical infection or يعني pneumothorax or like this.
Okay. So what part of the history led you about tuberculosis in this patient?
No, there is no, but maybe negative history. He cannot notice that he exposed to sick patient with TB like this, even. I think it's considered a routine investigation. I will do for him also bronchoalveolar lavage or sputum for any atypical infection or neutrophils or lymphocytes like this. I will refer him to the allergy clinic to do test for him name as RAST test for this for the allergen. If there is any allergen, we cannot know this allergen.
Okay, which allergen you are thinking about? There is a lot of allergens in the environment.
I don't. Maybe organic allergens like this. I'm not sure for. I don't. I asked him any changes in the job, but he said no changes. But I don't know what his job really.
Yeah.
Maybe this exposure to organic dusts or bird lung or farmer lung like this. Mushrooms, fungal infection like this.
Okay. So what's he do for living? We don't know, yeah? We don't know what he do for living.
Yes, I forget to ask him. I asked him about new changes in the job, but he said no. But I forgot to ask him what is your job.
Okay. So, yeah, I think you start first very nice.
I want to also to add differential diagnosis, but against this, I was thinking about charge stress syndrome, but he denied any symptoms regarding the kidney or blood in the cough or constitutional symptoms of vasculitis. It is one of the. Okay.
So, you are challenging the diagnosis of asthma. But do you suppose you are challenging the diagnosis? That I mean that you are thinking there is another disease, not asthma.
Sorry, again.
You are thinking there is another disease. It's not asthma.
No. First asthma because history is negative, but maybe the doses of medication is still, and this is severe asthma, and they still give him only oral inhaler medications only. So possibly to increase the doses for this asthma.
Okay. How you know that it's severe asthma?
Patient is still on inhaler and no response, still bronchial wheezing and these symptoms and cough by night. So not the grade of asthma is more than mild. So not controlled well by this inhaler.
Do you ask him how many nights per day, per week he woke up at night?
I asked him, he said to me recurrent, I feel I hear my wheezy chest every day night. He told me like this in the history.
Okay. Okay. So what do you think? How it's going?
How what?
What do you think this conversation goes?
This is your evaluation, not my evaluation.
From your side, what do you think? Evaluate
I
yourself.
think this is not. I think this is not easy scenario because no clue from the history or examination to refer me to the proper. But I try to search for all the possibilities that
Okay.
patient is not controlled.
Okay. So I think you start very well. That you first start by how the patient diagnosed with this asthma symptom. That's mean he had. Is it a diagnosed with peak expiratory flow rate or no? So this is very important. The other thing that you need to find out how many times per week this patient is waking up at night with the asthma symptom, and what he mean by his asthma symptom. Cough, wheezy, and I think you explored that, the cough and wheeze and the shortness of breath. The good thing that I think you asked me about orthopnea and paroxysmal nocturnal dyspnea to exclude there is no heart failure, masking the asthma symptom. You asked me about the inhalers. However, you didn't examine the technique. The patient taking the medication, is he taking it right or wrong? Okay.
Yes.
The other thing that this patient, he's not changing the job. We don't know what his job, and you didn't ask about the job, but he changed the house. So the new thing happened in this patient has for 6 years has been diagnosed with asthma, and his symptoms was controlled, and suddenly it's become uncontrolled. What make it uncontrolled? He moved to the other area. He moved to other house. You need to find out the housing condition. Is it a new house or old house? If there is any mold in the house. You asked me about dust. There is no dust in the house, but there is mold in the house. You need to explore, is this the symptom of the patient? Is it changed while he's at home or far away? Is the symptom mainly when he at home or when he go out? Okay, so the outside pollution, if you ask me, I will tell you whenever I came home, I feel my symptoms getting worse. Outside, he will become more better. Okay, and the other good thing that you are thinking about other diagnoses, but you didn't do bloods for the patient to look for eosinophilia. Yeah.
Bullets? What mean?
Blood, normal blood, full blood count. We start with the chest
This is
X-ray. We start with the chest X-ray.
This was the exam. Yes, eosinophilia, yes. It will be high. Otherwise,
How I know you didn't examine.
It will be high. It will be high because patient is still in bronchial asthma and not controlled. So it will be high. Is there a possibility that it will be normal?
It will be high, but we need to know it's a high eosinophilia. This can be eosinophilic asthma. Is it other cause? You need to see white blood cell if there is any sign of infection. If there is anything else. So yes. The blood is important here, isn't it? It's good that you explore that if he has gorge symptom, and this is good and the patient hadn't. The other thing that we need also the technique we talk about, and
Technique.
I think okay. I think also the family history. Did you ask about any family history of this patient?
I forget because I was looking for the patient himself. Yes, I forget to ask about family
I think
history.
yeah, this is the main thing if I remember. And you explored the systemic review well, but don't make the symptoms. Don't make it like you are making that. I'm saying to you that he have post nasal dripping and the things. If it is positive, positive. If it is negative, negative. So don't make the things. Okay.
Yes,
You need
yes.
to ask about over-the-counter medication. Maybe this patient is taking non-steroidal anti-inflammatory drugs or beta blockers or anything. As beta blocker unlikely, but medication that affect the control of asthma. So we
Yes.
need to look for that. We need to look for symptoms of with the general look for the patient. We need to see the BMI. You need to ask specifically. Maybe this patient have no asthma, has obstructive sleep apnea.
What is BMI?
BMI.
Body mass index. Body mass index.
Yeah.
Okay. Yes. Yes.
So
Maybe
to
is
see,
this
maybe he's obese and he has obesity, overweight syndrome. Not overweight syndrome.
Obesity hyperventilation syndrome.
Yeah,
Or
hyperventilation
obesity hyperventilation
syndrome
or
or
obesity
usually-
obstructive
obstructive
sleep
sleep
apnea.
apnea. Yeah.
Yeah, this is
Usually, hypoventilation syndrome, he did not have wheeze. But no problem. Okay. Yes, doctor. Continue. Continue.
this is from the differential diagnosis for your
Yeah.
symptoms. So the differential diagnosis for asthma, if it is uncontrolled asthma, you are thinking widely, yeah? Either this patient has uncontrolled asthma symptom because of something out like extrinsic or intrinsic factor. If you didn't find, your other differential diagnosis will be this patient may have heart failure, obstructive sleep apnea, hyperventilation syndrome, and gorge. This your differential diagnosis. If the case is not asthma.
Yes,
Okay.
doctor. Yes. Thank you, Wallahi, for this data. Thank you.
Okay.
Hypoventilation syndrome. Yes.
Yes, well done.
كملي يا
Dr.
دكتورة. Continue, دكتورة ميادة. Continue. What other possibilities for this uncontrolled asthma? You told me the technique, symptoms
Yeah,
at
yeah. You
house
ask.
more
You
than
need to ask
outside.
about it.
So
Yeah.
the new house. You told me about this mold and pollution.
Yeah.
Over-the-counter medication, body mass index, obstructive sleep apnea, heart failure, GERD, hypoventilation syndrome, or other diagnoses such as vasculitis, such as Uyghur.
Yeah. Vasculitis. You're right. Church
What
distrust. This one.
Yes, what
This
anything
is the main possibilities for uncontrolled asthma. The other differentials, but in this patient specifically, it is asthma because it's diagnosed and it was controlled and now it's uncontrolled. We need to compare the situation of the patient. You ask about traveling. This is very important. And what thing you need in traveling exactly is your symptoms is controlled while you are away. Maybe the area he's in is a problem. So when you ask about travel, you need to know exactly during traveling, while I am aboard, is my symptom controlled or no? If it is controlled, does something mean in the area I am in?
يا سلام عليك يا دكتور والله أحلى كلام جزاك الله خير.
الله يسلمك.
أول مرة تكلمي بالعربي وقعت بلسانك. أوكي كنتش عارف إن أنت عربية. أوكي يا سلام فعلا.
The same comment was I was about to say. I thought she's British. Dr. Maida is British in origin.
Oh, no. No, I am.
والله توقعت
But
انها
الله
اجنبيه
يسلمك.
فعلا، بس هي
Yes, الله
الله
يسلمك
يسلمك.
خلاص.
Allah يسلمك.
Break the rules. Okay. Thank you, Dr. Maida. It's very nice case, especially if you don't reach to the clue or the diagnosis. It's better to reach the diagnosis. Why? Because when you reach to the diagnosis or the cause of uncontrolled asthma, you will say, this is the cause, I will not scream more. So it will make more squeezed to know what is ongoing. You have to know what's ongoing. There is something strange in this patient. He was for 8 years controlled. Why just now, after 7 years, he's uncontrolled? You have to ask yourself why, and you have to have an answer for the patient. Why I am not controlled, doctor, although I was controlled well before. So we will search about every cause, either respiratory or extra respiratory cause, like GERD, as mentioned. The respiratory, of course, we know the technique, starting by the technique itself, the triggers, any triggers either from inside or outside, overlap with some other disease like Church-Strauss. Maybe he was misdiagnosed, but I don't think it will be for a long time. Or there
Yeah.
is recurrent infection, something lead to bronchiectasis, so the patient is not controlled with the secretion. Or vaccination, even COVID here, it's one important point to be raised, the COVID vaccination. But I am against mentioning TB, Dr. Mohi. Don't put differential, which doesn't make sense. Don't say TB and you didn't screen for TB. Believe me, they will minus you for this differential. To say maybe TB, it's not
حضرتك قلت انفكشن اهوت، انت حضرتك لسه قايل دلوقتي ان في انفكشن ممكن يخلي ريزيستنت
okay.
تريتمنت
Okay,
الازمه.
any infection, but
فيزيكال انفكشن هو تي بي، كان بي تي بي،
okay,
كان بي وان اوف ذا، ولا
okay.
لا؟ انا ما اعرفش، بسألك
No,
والله.
no, I'm saying
TB,
advice.
no, unlikely.
Unlikely,
ها؟
but if you want, Dr. Mohammed, if you want to mention TB as a differential, you have to have a clue for TB. Don't put TB as any infection. I mean, if your patient has contact with TB patients or travel to endemic area, and you specifically ask this question to the patient, and he said yes, okay, put it in very confident manner and put it in the top, okay. But I cannot say TB just for suspicion. If you mention TB without asking about the TB, this is a problem for you. Either to forget it at all, ignore it. Don't say a TB. Say any infection else. Patient has infection recently, a typical organism. But TB, you have to ask about the risk for TB. This is my advice, and don't put it unless you have a clue for it. Okay. The vaccination, as I said, now the job. As I hear, there is a drama about the job. You didn't ask the job, so the job is a must. Okay. We will ask now, Dr. Mayada, what about the job? You didn't tell us. Is it the trigger?
The main trigger for this patient is the malt at home. But he didn't ask about job. Maybe this can be triggered
Yes.
in other
Perfect.
scenarios.
Yes. There is a specific and
قلت
scenario
جوب يا
for
دكتوره
communication.
كمان.
Firefighter.
مم.
Dr. Mohi, there is a firefighter scenario for communication. The patient dream is to be firefighter, and now he has asthma because of firefighter, his job. So what you can address this point with him, how you can help him to work, although he has this asthma because of the fire, because of his job. Okay, so
أيوة. Yes.
you have to ask about the job. Why? Because whenever you have job related to chemicals, painting, any industry, if it is related to them by one question, do you think the symptoms worse when you go to the job, and when you are at home it's improving? Definitely you can put occupational asthma, your case or the diagnosis. If it is not, you can put it as a differential, so you can say differential occupational asthma, but you have to have some jobs related to the exaggeration of the asthma. Okay, So this is the another or second differential. The asthma as technique, you have to ask about the technique. So you will spend maybe 3 minutes just to know what is the trigger, the technique, the pets, the birds, the painting, renovation, changing the house, changing the job, his job. All the things you can address it as relevant system. Then you can ask about other symptoms like any short of breath, any cough of blood, and your system review, sorry, Dr. Muhi, was disorganized. If you come to ask the headache, the last question in the history taking, means your system review wasn't organized. Believe me, they will minus in the clinical.
Dr. Basim, because when from the outside, I put the differential diagnosis for uncontrolled asthma. I ask about all the causes, so I touch all the most of the systems. So I cannot ask them again and repeat them again. The only or least likely organs that can be it is neuro and connective tissue disease. So I make it at the end joint pain, skin rash, headache, checking of the body as a general يعني تحصيل حاصل يعني.
Okay, perfect. I'm not uh, arguing with you for the way you ask, the short time for asking for system review. No, collect all question related system review to be as once. So you will start with CNS, the neck, the chest. The chest already asked before, so you can skip to the.
الشيست والهارت والكدني كانوا في الاول خالص هما والجي اي تي عشان اكسكلود ذا
Okay,
بوسيبل كلوز فور ذا ديفرنشال دايجنوزيس.
okay. So you want to close the
Already
system review. I agree. Okay, you can ask them from the CNS downward. CNS, pituitary, any preference to bioder, and chest pain if you didn't ask earlier, any bloating or discomfort, stomach discomfort, any change in bowel habit, any change in the odor, finally joint pain or skin rash. Make it as package of question. Believe me, this is the way how they can judge you in the clinical communication. If you have minus in the clinical communication, the comment will be like this, unsustainable. Means he asked the headache after he asked the whole system review. Just train yourself if you want to ask system review, put the body in front of you and ask from up or down, from the head down to the toe. Whenever you want to ask about the systems, whatever, if you already asked before about any system, skip it, but you have to start in this way. So don't say muscle pain or joint pain or muscle or joint pain or skin rash, then you will finish the system review with the headache. Do you have headache? He will understand. Even I prefer not to mention the headache. Why? Because he will listen to the headache. Why he asked the headache now and supposed to be, for example, earlier. So skip it. Better than mentioning headache the last question. This is the first system you have to ask about. Again, this is my opinion and this is my approach. This is what I follow, and hopefully it can give you good mark. But everyone has approach. If you want to follow or not, okay? I think the discussion about this scenario, Dr. Mayada discussed it earlier, and she gave us the most common cause and cases. The technique you have to ask clearly. Have you changed your technique? And you can ask him like smart question. You ask this question at the end. What do you think, Mr. Ali, make your symptom worse? Okay, if you are stuck, you can ask this question. Do you think something changed recently, make these symptoms worse? You can say, yes, doctor, I notice it is, for example, if he's kind, of course, but if he's not kind, he will let you squeeze again and without reaching to the diagnosis. But if you don't, ask this question. And again, don't tell the patient something medical. Yeah, you have discharge, so it is this is the case. You can mention to the examiner, okay? But we are joking in the scenario, so it's good to make this funny way, just to release the stress we are in. Okay. Any question or comment from others? Sorry, Dr. Mahi, if I was tough for a comment, but I need for me to be perfect. Really, just try to
Thank
follow
you.
the approach. I know it's difficult to know the cases now, but whatever, I prefer not to know the case today rather than in the exam. In the exam, you have to know the case, the differential, the examination, everything. Don't miss the right side heart failure. Sorry, not the right side, the right side pressure. It's important to check for parasternal heave and for loud B2. Why? Because any patient with chronic lung disease, he might have secondary right side heart failure or pulmonary hypertension signs. Okay, clear? So the differential
Okay.
again, the asthma, you can say occupational asthma, you can say drug-induced asthma if you, of course, have asked about any drug or any over-counter medication. Non-steroidal, one of the cases in I think in one of the book, I think a Roch box, there is non-steroidal anti-inflammatory drug-induced asthma as a cause. So we'll look for the all causes, and finally you will find the patient has, for example, joint pain. He received non-steroidal anti-inflammatory drugs, and this is the trigger for his asthma. You have any question, Dr. Muhi?
لا خلاص بس كنت عايز اسال الدكتوره ميادة، هي سالتني في الاول انت شايف نفسك ايه، فعايزه هي تجاوب على
Yes.
السؤال ده.
Okay, this is also good to comment on yourself. What do you think about your performance? It's you can ask her also when she finish her question. If you want her comment about your performance.
For me, you have a good start, and you keep asking good questions, but you need to concentrate. Don't. I think you are putting a specific thing in your mind, and you ask for it. Try to be flexible and put the differential diagnosis, sensible differential diagnosis, so you can ask more better. There is area for improvement anyway, but you start start good. Your structure was good, but at the end you miss important things that make the scenario a little bit difficult to you.
And adding to this sentence, if the things you missed, next time you'll not miss because you learn from the mistake. The last comment, whenever
دكتوره ميادة, what I miss is that the question that in the new house.
Yeah, this is the main thing. Yeah, this is the main thing that you catch this from the start, that this patient changing his house. So there is some change.
Yes, I asked
You
her
ask,
this question.
so in the house, then now come in the house. What is the new? Why this house make this patient? Because even if you ask me and I told you I have mold and everything in the housing condition, if you ask in the social, how you can help this patient?
دكتور
Will be
باسم
my
يعني
concern. The next concern, if you told me that I have more, I told you I have mold at home and everything, then it will be one of my concern. So how can I solve this problem?
يا دكتور باسم يعني ايه مولت دي يا دكتور باسم؟ مش عارف.
it's like plants. Plants.
ايه؟
Plants. Plants. Plants.
plants.
شنو مولت؟ التخمر، مش تخمر، هو فطريات، مش في اللي بتجي مع المولت في البيوت لما يكون mainly في البيوت اللي بيكون فيها
رطوبة
الرطوبة
يعني.
ايوه
الرورال
هو اسمه
يعني
العفن.
القش.
ليه؟
ايوه
مش مقصود
بالعفن.
rotten on what? Rotten what? Rotten food, rotten plants, rotten what is rotten at home? Anyway, you have to ask about any
والله يا
strange
دكتور
thing.
باسم انا سالت السؤال ده، قلت لها any new changes in your house, the new house any changes، بس السيروجيت يعني كان اناني وما قالش الحاجات الجديده.
دكتور باسم it is well known in their environment this mud. That's why they are cleaning and maintaining their ventilation and the system of the cooling and like this. They're maintaining every time because it is well known in their houses. It is also well known
because
in the
no sun
places.
exposure. Yeah.
Aywa, yes.
Yeah.
It is also, I think, here in Saudi Arabia, like in Jeddah, the places where there is very too much humidity, you will find this mud. هو exactly بالعربي العفن اللي هو بيتكون لما يكون الجو humid.
Okay.
فعشان
Yes.
ايوه old houses. Why especially old houses? Because they know that in the old houses the ventilation system is old, not renewed. That's why they have this mud in their houses. So this is in relation with England, unlike this, and the exam is from England. That's why.
Yeah, perfect. Thank you, Dr. Salma, for clarifying the thing. Uh, it's okay, Dr. Mahi, don't feel mad that you didn't get the case. Believe me, this case you will never forget it again. And you will thank Dr. Mayada if the case come to the in the exam. So forget like
بس هي حاجة غريبة والله
no, 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 no,
حكاية
Dr. Mahi,
mold
please
at
don't
house.
feel like this. Don't feel like this. Even you didn't approach or didn't reach the diagnosis. It's not the matter here. The matter in the exam. Believe me, in the exam, if you know the case better than today, that you are perfect now, but in the exam you forget, for example, this point. So better to learn from the mistake than from the perfect performance now. Okay, you will not forget it again. The last comment, Dr. Mahi, if you allow me, whenever the examiner asks you investigation, take a breath, take a breath. Don't start by just chest X-ray. Okay, yes, chest X-ray you will do it, but you will miss a lot of tests, like blood tests. As I said, start by blood test, general investigation, specific bedside, and let him ask you whatever he wants, because he might ask you what's the bedside test you want to do. You will tell spirometry. It's the best diagnostic tool for obstructive lung disease, right? Flow cytometry
Yes.
or so ABG. You have to let him to give him a chance to make a challenge with you, what you know about the investigation in systematic way. So don't rush to answer the examiner. Just X-ray. No, take a breath and start to answer in stepwise manner. General, specific, bedside, imaging, invasive tests. In this, what invasive you can do in this patient, for example? And by the way, it's diagnostic for external
Bronchoalveolar
allergic
lavage.
events. Perfect.
Bronchoalveolar lavage.
Yes. So he might ask you this question and we'll give you full mark. So don't start
Yeah.
by just mentioning anything. X-ray, chest, high resolution CT chest. What about blood test? You will not start by blood test. You will not do ABG. Whenever the patient arrives to the emergency, we are taking ABG. This is the VBG, venous. The first test, just to have a look for the electrolyte, the acidosis, particularly if he has a respiratory problem. Okay, this is the last advice. Let's go to the second scenario. Dr. Mahi, can you write the scenario for Dr. Mayada?
Okay. This Miss Mona, 32 years old, presented with easy using heavy periods. GB did for her CBC and found platelet count is 9, and here is the patient to you.
Miss Mona, how old? 35.
Platelet 9.
Yes.
Okay. 2 minutes.
Take your time because I want also to prepare for you the scenario.
Okay, I will try to read the comments quickly. Good differential, Dr. Aisha. Thank you. Poor technique, subdose or right choice medicine, and insufficient, you mean. Allergen at home or work, wrong diagnosis, allergic aspergillosis, reflux GERD, rhinosinusitis, atypical infection. Perfect. And accordingly, you have to roll one by one and to put according to the history, which is fitting the case as a differential, whatever you find. So if the patient tell you, I feel like acid flush in my mouth or acid taste in my mouth, this is J. Difficulty of swallowing. I feel uncomfortable with my throat. I am coughing a lot because of some fluid. Okay, this is how to ask and how to put as differential. Always put the differential which is related to the history. Dr. Sarah, could be allergic bronchopulmonary aspergillosis. Yes, could be, particularly if you have history of asthma and complicated by fungal infection. Yes, it is one of the asthma presentation. And you have also brownish, by the way, you will have brownish sputum. Dr. Ahmed, past medical history, maybe he is taking immunosuppressive medication. That's why we have to ask about medical or medication list. Differential diagnosis, Dr. Zoom, already Dr. Marwa, Dr. Aisha mentioned. Dr. Marwa, but why technique? He was controlled before that, mean he know the technique. Yes, but we have to ask the question to show the examiner that we are taking care of the technique. Okay. Of course, we have to know the doses, the technique, anything might interact with the medication. I like when Dr. Mohi asked about the tremors. So you might have tremors, either fine tremors with the beta agonist, salbutamol, or you might have flapping tremors for CO2 without filling. So it's good to mention the tremors and to examine for it. Yeah, we already discussed the point of firefighter technique and healing. Yes, renovation venting. Also, question as a venting is important. It might be a trigger. Patient renovate the house, or is some persons are interested to make the painting by himself. And if he's asthmatic, of course, he will have exaggeration. AC inhibitors may cause cough, but it's not asthma. So the complaint will be cough. It's difficult during the asthma. Extrinsic allergic alveolitis could be as a differential, but it will not be obstructive lung disease. It could be restrictive lung disease. Dr. Sarah. It's one of the restrictive occupational pneumoniasis. Okay, Dr. Salma, what about ABBA? Yes, we mentioned already, can be. How do I explain COPD to the patient in non-jargon way? Yes, Dr. Ahmed also mentioned obstruction narrowing in your airways or air pipes or ways or air pipes. This is non-jargon way. Any question before moving forward? Dr. Any question before asking Dr. Mayeda if we can start?
السلام عليكم دكتور باسم.
عليكم السلام Dr.
Sarah, I didn't hear your comment about extrinsic allergic alveolitis.
Yes,
Is
it's
it one of the
restrictive.
differential?
No, it's restrictive disease, not obstructive. It's restrictive lung disease.
Uh-huh. I think
It's like
from the
fibrosis.
symptoms.
So you will have cough, but you will not have wheezes. You will have cough.
Okay.
Okay, this is the main difference. And by the way, it's triggered also by some of the fungals, but it's not as obstruction. It would be fibrosis and restriction or restrictive lung disease in the spirometry. So you will mention the forced expiratory volume 1 divided by forced vital capacity more than 80. But in our case, asthma and COPD, It would be less than 70. It's an important question, by the way. And you have to mention spirometry in any chest scenario. Any chest short case scenario, you have to mention spirometry. Because he will ask you how I can know the disease from the spirometry. This is a mandatory question. Any question else? Thank you, Dr. Sarah. Any other questions? Any comment?
Sorry, Dr. Wahi, can you tell me the name of the patient and the age?
She's
Miss
Mona,
Mona.
35, right? I wrote in the chat box.
Okay. That's fine.
If you're ready, we can start.
Yeah, we can start.
Okay, I will set the timer. Okay.
Hello, my name is Dr. Maida, one of the medical doctors here. Just I want to confirm that your name is Miss Mona, 35 years old.
Yes, I am doctor.
Hi, Miss Mona. What do you want me to call you?
Miss Mona.
Miss Mona, okay, thank you. Just I understand that you come with the heavy period. Do you want to tell me more about it?
Yes, doctor, over 3 months now, I feel tired, and also I feel that some blood come from my nose. And sorry to tell you also, my period become heavy.
Mm-hmm. Okay, so this happened over the last 3 months. Do you have this symptom before, or this is the first time?
Yeah, this time.
First time. Okay, you told me that you have heavy periods. I mean, you have a lot of bleeding from your cycle. And also bruising, and also you have bleeding from your nose. If there is any area of bleeding, do you know? I mean from your
Also,
gums.
yes, one time come from my gums. During I do brush my teeth, I found that blood come, yes.
Okay, so do you observe any skin, any rashes on your
No,
body?
no skin rash, but I also exposed to even mild trauma. Some bleeding come below my skin.
Oh, okay, okay. Do you have any bleeding from, do you ever vomit blood
No, no,
or you cough blood at all?
no, no.
Okay. And you told me this happened over the last 3 months. Okay, do you
So,
have, yeah?
okay. Now also 2 times or 3 times bleeding come from my nose.
Mm-hmm. So you have bleeding from your nose and from your sometimes from your gums and also from the cycle. Do you have any fever at all?
No,
Do you have any weight loss recently?
no, no,
You told me that you feel fatigue. Do you ever have headaches?
no,
Okay. Do you feel your heart racing?
no,
Okay. You have no fatigue at all.
no. Recently, no, no fatigue. No,
Okay.
no
Do you have any short of breath?
no.
Okay. You had. What about your appetite?
My appetite is okay.
Any lumps or bumps in your body?
No,
Do you have any recent infection?
recently, no.
Okay. What about? You told me that you have rashes. It happened when with simple traumas. Do you have
No
any
rash.
joint pain?
No, no rash. Only bleeding, doctor. Bruises around my skin, under my skin.
Okay. Do you have any joint pain?
No,
Any swelling in your joints?
no,
Okay. Any change in your skin color? That's or eye? Is it retaining yellowish at all?
no,
Okay. Do you have any tummy pains?
no,
Okay. And any change in your bowel at all? No change in bowel. Do you throw up or about to throw up, like nausea?
No,
Do you have any night sweats?
no,
Okay. Do you have any lumps or bumps in your body at all?
no.
Okay. Apart from that, I want to ask you some questions. You told me that you have no headaches. Do you have any weakness in any area in your body?
No weakness.
Any change in sensation at all?
No abnormal sensation.
I mean, if you have numbness or tingling sensations.
No, doctor.
Do you ever have blurring of vision or loss of vision at all happen to you?
No,
Okay. Do you have constipation? Constipation.
no heart motion, doctor.
Constipation.
No,
Okay. And no diarrhea as well.
no.
Okay. I will examine you while I'm asking you questions. That's okay. Hello? Okay. Do you have any illnesses I should be aware of?
Yes, doctor, yes.
Do you have any illnesses?
I don't have any past medical history other than about 4 or 5 months back. I have only flu-like symptoms, but nothing else.
Okay. So these flu-like symptoms you had, do you have any specific diagnosis like COVID or?
No, doctor. What is only is for 2 to 3 days, and it is improved
Okay. Otherwise, you have no chronic illnesses.
by its own. Otherwise, I don't have any past medical history.
Okay. Do you take any medications?
No, I'm not taking any medication.
Okay. Any over-counter medication?
No,
Meds.
Ibarka.
Okay. Do you have any antibiotic recently?
No,
Okay. Do you have any allergies?
no.
Okay. What about your family history? Can you tell me if there is any similar condition in the family?
Like what, doctor?
Any similar condition like you, that's bleeding
No,
disorders in the family?
no one have bleeding.
Okay. Any heart problem or liver problem in the family?
No,
Okay. Where you are living, Miss Mona?
where I am living
Yeah. I mean, you are living alone or with your family?
with my family, yes.
Okay. What do you do for living?
I am a teacher, doctor.
Okay. How these symptoms affect your job?
Yes, doctor, I usually feel bleeding from my skin, from my gums, from my nose.
Mhm.
I feel stressed and I'm worried. So I am not concentrating in my job. I feel this is a cancer or anything risky.
Mhm.
So I came to you today.
Okay, I'm so sorry for feeling like that. We'll try to help your problem and to find out the cause. Do you smoke?
Yes, I smoke
How many cigarettes?
10 cigarettes per day for about 5 years now.
5 years. Yeah. I think smoking is a hazard for your health generally. If you willing, we can refer you to sedation clinic if you want. It can help the symptoms and can help your health generally. It does sound good to you.
Yes, doctor, I will stop smoking.
What about alcohol?
Yes, I drink alcohol, but occasionally at the weekend with my friends.
Okay. Do you have any history of trouble?
No.
Do you have any, sorry, I will ask you some personal questions if you give me a permission. Do you have any, are you married?
No, I'm not married.
Do you have any casual relationships?
No.
No casual, okay. About your cycle, you have these heavy menses, and previously your cycle was regular?
Okay. Yes, it was irregular and it was okay.
It was regular, okay.
Two times now it become 2 times now it become heavy. 2 times.
Okay. Is there any possibility that you are pregnant?
No, doctor.
Or
No.
okay. Now I will examine you.
Okay.
I will start with general appearance of the patient. I look for pallor.
Some pallor, yes, because of recurrent bleeding. Yes, patient has pallor.
Okay.
Yes.
Okay. Then I will examine the skin for petechiae and purpura and ecchymosis.
No purpura, but there are 2 sites for the bleeding under the skin. Bruises.
Okay. I will look also for active bleeding sites, the nose and the gum.
No.
Okay. In the eyes, I will look for jaundice if there is any
No
jaundice.
jaundice. No jaundice.
The mouth for gum bleeding and mucosal petechiae as well. If there is any mucosal petechiae in the mouth.
No.
Okay, then I will examine the chest, first and second heart sound, and looking for murmurs and sign of heart failure.
There is soft systolic murmur on the apex, and the patient has tachycardia, looks regular, but no signs of heart failure, no rise of GVB, no crackles, and no organic structure of the heart.
Okay.
Apex is in place.
Okay, then I will go to examine the abdomen for hepatosplenomegaly.
No splenomegaly, no hepatomegaly. No.
Okay, then I think I will start from. Then I will go to examine all the lymph nodes, looking for any lymphadenopathy.
Yes, no lymph nodes.
Okay, I will examine the joints for tenderness or swelling as well.
No.
Okay.
No joint. Some arthralgia, yes, but no arthritis, no signs of arthritis. Symptom only. Okay.
So, Ms. Muna, can you tell me what's your concern at the moment?
Yes, doctor. Why? What do I have?
Yeah. Okay, Ms. Muna, your GB sent the blood tests have been done to you, and we found that you have low platelet. The platelet, this is a blood component important for to keep our blood not to bleed, to keep us from bleeding, and it's very low. We are trying to find out the cause why you have these symptoms, and at the moment, I am not reaching the exact cause of why you have low platelets, but we need to run some more investigation in your bloods, and we may need some images as well. And also we will involve a multidisciplinary team that including the blood doctor, and to find out what the main cause. At the moment, because you have this active bleeding, I will admit you to the hospital for further investigation. If that sound good to you?
2 minutes left.
Yes, doctor. Thank you, doctor.
Um,
So you until now you don't reach the diagnosis, doctors, huh?
Yeah. So the main diagnosis that you have low platelet. We have the why you have these symptoms, but we don't know why your platelet is low. Okay. We need to look for the blood in general. If it is all the blood component is low, or it's just the platelet. Just can I ask you one more question? Recently, do you feel like you have recurrent infections?
I told you, doctor, 4 months back, I have flu symptoms in my nose, and runny nose, and like this.
You told me that once. Did it happen
Only
always?
once, doctor. Yes,
Only once.
Only
Okay.
once recently, but before 1 year back, 2 years back, every season in the winter, I can take this common cold.
Okay. Okay, I understand. Do you have any symptom like frequent urine?
No, no, my urine is okay.
Okay,
And
or
no blood
pain
in my
while in your
No.
water work? Do you have any pain?
No pain in my water work.
I think. Yeah,
Thank you, doctor.
thank you. I have no more questions. Still I have time, yeah?
لا خلاص finish.
Mhm.
لو عايزة تسألي حاجة تانية, okay, you can ask if you want. If you wanted to ask one question more, or we
Okay.
still under training.
Okay, so is there any blood from your urine or from your water work or from your back passages?
No, doctor, no.
Okay.
Only from the skin, nose, and gums,
Mm-hmm.
and heavy menorrhagia or heavy cycle. For 2 times only.
No more question. No more question. Okay, time up. Dr. Basim?
بس
Yes, time is up. Let's start exam.
Okay.
So, Doctora, what is your differential diagnosis?
Okay, I present this case. First, so this lady come with the bleeding from, she has a bleeding, heavy menses and nasal bleeds with petechiae hemorrhage. She has no symptom indicative of malignancy or infection as a cause of her symptoms, and also she has no symptoms indicate she has no history of travel to think about infections like malaria or dengue fever. As well, this lady have no history of previous medications. She has no clinical sign of
What is the medication?
decompensation.
What is the medication may be related to this case? If the patient has medication, what is the medication you're thinking in?
Like non-steroidal anti-inflammatory drugs and quinines, antibiotics, and
What it will cause this antibiotic? Which antibiotic and what it will cause?
Like I'm thinking mainly about non-steroidal anti-inflammatory drugs. It can cause the platelet to non-functioning platelets. And
Non-functioning. But here,
yeah,
platelet count here is 9.
9.
The GB, yes. So this is platelet count, not platelet dysfunction.
Mainly, yeah. But you are right. Also, she has no history of liver disease. She's not drink alcohol a lot, and there is no sign
What is
of
that?
liver disease.
You asked me about malignancy and lumps and bumps and weight loss and that. So malignancy, it is a differential diagnosis. What is the malignancy that can cause this low platelet count?
Leukemias.
Yes, very good, doctor. Yes. What else you should ask in the history as a differential diagnosis to rule out?
Viral infections, like I ask about relationship in deep.
If there is viral infection, if there is
Yeah,
viral
HIV.
infection and the patient ask you, he told you 2 times in the history that he has flu symptoms 4
But
months back.
once,
So
yeah,
so
but
what
once,
is the viral infection? Yes, this viral infection, what is the relation with the low platelet count?
The viral infections which I'm thinking about, in fact, like HIV, hepatitis, and the otherwise, I don't think Epstein virus, is it causes flu-like symptom? No.
Yes, it can be. Any virus can cause, but what is if there is viral infection and the platelet count low? What will be the diagnosis at that time?
I'm not quite sure.
Okay. What else? What else can cause this low platelet count?
Alcohol abuse, but she has no history. It's history of alcohol abuse.
How alcohol will cause low platelet count? How?
It affects liver. It can cause liver cirrhosis and liver dysfunction and low
But
platelet.
liver failure, it will cause platelet dysfunction, not platelet count low. Is that right?
Both
I'm not
both
sure.
of them.
Both of them. Okay. What else? But here in the examination, there is no hepatomegaly, no signs of
Yeah.
chronic liver disease, no liver failure. Fine. Okay.
Yeah.
What else?
Against it. ITB and TTB.
Yes. Yes. Now you reach the diagnosis. What is TTB? What's this TTB?
TTB, I think neurological symptoms as well will be there.
Yes, neurological symptoms and renal failure, fever, microangiopathy,
In
okay,
TTB,
anemia, and the platelet count low. So the remaining is what else?
yeah.
This ITB. What's this ITB? Can you explain to me more? What's this ITB?
It's idiopathic.
Yes, idiopathic or يعني okay, idiopathic
Or
thrombocytopenic
autoimmune. It can be like autoimmune disease, lupus. So I add
Yes.
the joint pain and everything, but there is no
Yes.
indicative of connective tissue disease.
Yes, lupus, systemic lupus can cause this ITB, one of the differential diagnosis. So this ITB is a disease of exclusion, okay?
Yeah.
Now you told the patient that you will admit him. What you will do for him inside at the hospital?
Okay. First, we need to investigate. We'll start with general investigation. I do full blood count for this patient to look for any other, if white
You
blood
did
cell,
CBC?
if it's
Yes.
pancytopenia, or
Okay. You did
if
see
it
you
is
did CCB?
pancytopenia or
Okay. You
liver function.
okay.
Sorry, I can't hear you.
You did CBC and you found that hemoglobin is 8 and the platelet count is 9 and the
Yeah.
white blood cell count is normal. So what you will do according to this test?
Okay, according to this test, first I need to stabilize the patient first. I will give him bloods and platelet to stabilize the patient because he's actively bleeding at the moment. And then I will refer to hematologist.
You will transfer. Yes. You will give him platelet transfusion?
Yeah, I will give him platelet because she's bleeding now. She's actively bleeding.
Okay. Then what else? What else? Other medication, other therapy, active therapy for him?
I want to look for INR, BT, and ABTT. I also look for
If we diagnose, yes, if we diagnose him as ITB, what do you expect for the BT, BTT, and INR? How it will be?
raised.
Raised.
Yeah.
Okay, doctor. خلاص ده 7 دقايق أنا هريتك أسئلة. Just be 5 only, 5 minutes. Thank you, دكتورة ميات.
Heretic assault. But really, it's a nice case with nice question also. We learned from this question and challenging one. I think all of us chatting in the chat box trying to reach also. Thank you, Dr. Maeda. Well done. Let's hear the comment from Dr. Mahi, then I will comment. Dr. Muhi, your comment.
In fact, I think it will be normal, yeah. It
Yeah,
will be
normal.
normal
Yes,
because
normal.
it will
Only
not affect.
platelet
Yeah,
count.
normal because it's
Exactly.
not affect. Yeah, it's not
Yes.
affecting the coagulation profile.
Perfect. Yes. Dr. Muhi, you can comment now.
بس one comment بس إنه in this patient if platelet count is below 30
Yes.
at that time we will
According
give
to guidelines.
patient corticosteroid or IV immunoglobulin. I will not transfer for him platelet because it will be distracted again.
Distracting.
Yeah.
This is
Yeah,
a
so-
case of increased destruction of the platelet. Okay.
Yeah, right.
Differential diagnosis for this case: ITB, TTB, DIC, systemic lupus, lymphoma, HELB syndrome, and the case of us now viral infection. ITB is a disease of exclusion. Okay, patient has viral infection, then incubation period, then develop this bleeding. It is not a must for any ITB patient to have berbera. Maybe only bleeding over gums, only heavy period like this. And it is a disease of exclusion. And during your examination, one thing will help you. There is no there is no splenomegaly. So lymphoma excluded, leukemia excluded, like this. Okay. That's what this. One of the differential diagnoses, yes, systemic lupus erythematosus. So you ask about joint pain, skin rash, and I exclude it. Okay.
Yeah.
So this patient, we will give her prednisolone 1 milligram per kg per day if platelet count is below 30. Okay. If there is severe bleeding, يعني CNS bleeding or bleeding in the back passage or urine and severe, like so, at that time we will give him immunoglobulin IV. Okay. If platelet count is still below 30 after we start this active treatment, for after 3 months of corticosteroid, we will do for this patient splenectomy. We can give also azathioprine. اوكي. يعني معلومه كده خارج السياق، احنا بنخش على بليتلت كاونت. بالنسبه لبليتلت كاونت it can cause bleeding if there is platelet count low or platelet dysfunction. A platelet dysfunction it is von Willebrand disease or Henoch-Schönlein-Berg. Okay. This cause platelet dysfunction and liver function, liver failure, as you told us. Liver failure can cause platelet dysfunction also. يعني تمام. يبقى الحالات اللي هي cases that has platelet destruction: ITB, TTB, DIC, systemic lupus, HELB syndrome, lymphoma, leukemia, and post-viral infection. After approach for the patients with low platelet count, you in the differential target question to rule out the causes, weight loss and constitutional symptoms, and to exclude malignancy, lumps and bumps. You ask about pregnancy and the HELB syndrome and this preeclampsia. Then ask about CNS manifestations and for thrombotic thrombocytopenic berbera, which it can cause after infection with GIT infection, systemic lupus by skin rash, and then disease of exclusion by ITB. Okay. If platelet production is low, bone marrow failure, such as mumps, Epstein-Barr virus, HIV, alcohol. So alcohol can cause bone marrow يعني suppression and decrease production. Okay. Vitamin B12 deficiency. And the abnormal platelet function, Henoch-Schönlein-Berg, von Willebrand disease, and liver failure. Okay.
Yeah.
One of also the platelet count low, aplastic anemia. And this aplastic anemia, it has pancytopenia due to bone marrow failure. Okay.
Yeah. Nice guess.
Thank you, Dr. Amayo.
Yes. X-ray, yes, I will order now. Wait. You order? I will order this. Give me just some time. Thank you, Dr. Muhi. Very nice case. I don't know, both cases today challenging and also difficult. However, Dr. Mayada, I think she reached at the end by one clue, which is the recurrent infection, or even one infection. It's a matter of trigger by viral or by infection. Then it's associated with some other autoimmune, but it's not necessary to be autoimmune. The bleeding here, as Dr. Mohi said, it's related to the platelet count, not function. Of course, the function will be affected because of the count, but mainly by the count. So all blood work up as a coagulation clotting factor will be normal. Only the platelet count, which is clearly, obviously affected, will be the abnormal finding. Let's talk about von Willebrand. Some doctors mention von Willebrand, so it will be like inherited condition. I should mention it whenever the patient started to have this bleeding since childhood. Okay, so you can ask any previous attack of bleeding per gum, and so on. But if he has just recently this bleeding, it's out of von Willebrand disease. ITP as a common in female, it's very common in female. And I know one case in 30s, in early 30s. She was diagnosed with ITP. She received steroids till she had bleeding, and she tried another medication, rituximab, I think, or some of the monoclonal or biological therapy. However, she had one day severe headache without any trauma. She had a headache. They admitted her and they misdiagnosed her like sinusitis. Then the next time she had seizure. Unfortunately, when they did the CT next time after the seizure, patient had subarachnoid hemorrhage. Unfortunately, she went into a fatal complication, which is brain herniation, and she became brain dead. Supposed to have splenectomy, other lines of management. So it's very sensitive topic. If you just make it slightly, you might miss the case and you might lose your patient. Please focus in the diagnosis, especially in female, young, without any other history of medical condition, just infections, and you might have the ITP as a diagnosis. Okay. The other definition, of course, is already Dr. Mohammed mentioned, but HELP syndrome supposed to be out, as Dr. Hatem also wrote, it's with pregnancy. It's not, you have to say against that, there is no pregnancy. Yes, you can put it as a definition, but you have to mention against that the patient is not pregnant. Of course, preeclampsia as well, but the patient is not pregnant. The system review, Dr. Mayada, I think also it wasn't that organized way, but you miss a lot of history, like family history. It's very important to mention.
I asked about the family
You
history.
ask? Okay. Sorry, I am on duty. That's why sometimes I cannot hear focused. I think also very important here, yes, some advice regarding avoiding vigorous exercise. It's very important, and the job you have to give her, because by the way, if this patient have just mild head trauma, she might go with the ICH, mild head trauma, because platelet is 9, it's a fatal number. Less than 10, Dr. Muhi, for transfusion. The guideline says if platelet less than 10, even if no bleeding, you have to transfuse the patient. Even it will be distracted, but you have to transfuse. If platelet less than 20 with no bleeding, okay, no need to transfuse. If less than 20 with bleeding, you have to transfuse. Whatever the condition is, okay, either ITP, TTP, whenever the platelet less than 10, it's cut off to transfuse platelets. Okay, this is what I remember. But if I think Dr. Sarah, she was the hematologist, or Dr. Zainab, sorry, hematologist. If she has comment about this case, please, you can talk, Dr. Zainab, if you are with us. Hello, Dr. Zainab, are you with us? I think she's with us still, but maybe she's not hearing us. Okay, any comment from others? Any question, Dr. Mayal?
No, thank you. This is nice case because
Yeah.
you refresh the hematology.
Hematology, yeah.
I'm more
Did you examine the spleen, Dr. Mayada? Sorry for this interruption. Did you examine the spleen?
sorry?
Examining the
She asked
spleen.
me, yes, sir. She asked me, and I told her, no, hematomegaly is benign.
Okay. Particularly, you have to ask it in the history. Do you feel discomfort? And you have asked already for
Abdominal
feeling
distension, yeah, abdominal pain. I
distension,
asked
pain.
about abdominal pain
Perfect.
and examined for splenomegaly
Yeah,
and acromegaly.
perfect, perfect. The jaundice also. The liver supposed to be in the top of your differential, particularly if there is trigger for the liver, like alcoholic, like even metabolic syndrome, fatty
I
liver.
asked about yellow discoloration of
Yes, I
asthma.
remember. Yes, yes, I remember about the jaundice. Okay. Any question from others or comment? I will read the comment quickly. ITP, Epstein-Barr virus, systemic lupus, enoxaparin. Yes, blood thinning medication. You asked already, right?
I asked about medication. Generally, he's not on any medication.
No, you have to specify blood thinning medication because you have bleeding everywhere. You might have warfarin. Simply, the patient will be on warfarin, and this is the case.
Heparin C.
Warfarin or heparin, any medication.
Heparin, not warfarin.
No, you mean for the platelet? Yes, you're right. But in another case, you might have warfarin for metallic valve, for example, and patient present with bleeding, and with the history, he will not mention for you warfarin, for example. But if you ask particularly about blood thinning, he might say, by the way, the examiner might instruct the surrogate, don't say unless he asks about it. So he might tell you, no, doctor, I'm not taking any medication. But if you ask for the medication list, for example, you will survive. There is heparin or there is warfarin. But this is the instruction. Suppose I will not tell you, you have to ask me particularly, or you will check it in the medication list. That's why please ask for the medication list for any patient. Okay, hereditary telangiectasia, I don't think, because it was without thrombocytopenia. The hereditary telangiectasia with no thrombocytopenia. Ask the drug thinning indication, perfect. Myeloproliferative, yes, of course. If there is constitutional symptoms, you have to put lymphoproliferative myeloproliferative disorder as a cause of that. Thrombocytopenia, enoxaparin, thrombocytopenia, yes, agree. Anyone know what is the complaint? It was bruises, low platelet, and heavy periods, bleeding nose, thrombocytopenia. Essential thrombocytopenia, it's not a common in cases. However, it's called essential thrombocytosis, Dr. Salma. I don't remember essential thrombocytopenia. I don't think there is essential thrombocytopenia. It's essential thrombocytosis. Abdominal discomfort, splenomegaly, yes, Epstein-Barr virus, hemorrhagic fever, perfect. If there is travel history, dengue fever, or any hemorrhagic fever, one of the possible differential. Patient will have bleeding from everywhere, but the patient will not have only low platelet. He will have all coagulopathy, bleeding tendency, like high PTT, high PT, high NR, low platelet, low fibrinogen. Okay. Antiphospholipid cause thrombocytopenia, but not very low like this. Yes, agree. What is the diagnosis? Anemia, antibiotic thrombocytopenia. Yeah, this is the diagnosis. Bone marrow depression due to the yes, of course, methotrexate sometimes, but you will have anemia, not only thrombocytopenia. TTB, yes, you can put it, particularly if the patient is having neurological symptoms and kidney failure with thrombosis, risk of thrombosis or signs of thrombosis. Bleeding time will be affected if you have von Willebrand. And in this patient also you can have bleeding time raised or prolonged because of dysfunction of the platelets, plus the platelet count. Autoimmune dengue fever, autoimmune dengue fever can be as a differential, particularly with history of travel. You can give tranexamic acid. I don't know. This is Dr. Zainab. Yeah. she has a comment about tranexamic acid for the heavy period, in addition to IVIG. Yes, IVIG, one of the lines, by the way. Yes, you're right. Thrombocytopenic agent also give before going splenectomy. Yes, we have to correct before doing the splenectomy because it's a major surgery. Dr. Wala, investigation, treatment, the case, low platelet, bleeding again. Yes, we have to correct the thrombocytopenia as guidelines, transfusion according to the count. Transfusion in case of massive bleed, like brain bleed. Yeah, of course, this is a must. You have to correct whenever there is major bleeding. HELP syndrome for pregnancy, agree. Should ask about symptoms of anemia, of course, and she asked. Thank you, everyone. Dr. Mohi, Dr. Mayada, very nice cases today, and I think this session is very important to hear from everyone because the asthma as a presentation and also the low platelet and easy bruises, one of the difficult and less common scenario in the exam, but if you do it in good approach, you can approach the case properly. The investigation, Dr. Wala asked for the investigation. Again, general, specific, bedside, imaging, invasive. General CBC, you will look for the platelet count, coagulation profile. Specific here, you can do some antibodies, but it's not for the ITP. ITP as a clinical, Dr. already Wahi said, and this is by exclusion and clinical diagnosis. If you have female patient in young with no other manifestation, only bleeding with low count, you will not find anything. But you have to do all the autoimmune workup to rule out any autoimmune or connective tissue disease. You have to do, but you will not find anything apart from the platelet. The last thing is bedside test here. You can, for example, check in urine the mistake for hematuria. Patient might have hematuria. You can say bleeding. By the way, bleeding time is bedside test. They are not doing it manually. It's not a laboratory one. And then the imaging, you will do ultrasound to check for splenomegaly, hepatomegaly to rule out. Don't forget the liver function test and lipid profile to rule out liver as a cause, chronic liver disease. Then the invasive test here, I don't think there is invasive test here, but you can do the surgery, which is splenectomy. Blood film is important. Yes, thank you, Dr. Zainab. I asked earlier about your opinion. If you want to talk, we can hear you. Autoimmune and viral, yes, screening, yes, you're right. Bone marrow aspiration as well, if the coagulation profile is okay. Okay, Dr. Zainab, as hematologist,
Yeah.
you want to add anything?
Yeah. So we
Yes.
don't usually transfuse the patient even if the platelet less than 10, unless they had like massive bleeds, like because they're gonna destruct again and you're just gonna keep transfuse every time. So we don't usually transfuse unless they had a bleed or they had an infection and they develop a fever or something like that. You do give them platelet. It's also very important in the history to ask about blurry vision and headache to exclude the intracerebral hemorrhage and stuff like this. And I spoke about the tranexamic acid because she was saying we should transfuse because of the heavy period. So I was just saying you don't need to transfuse for the heavy period. You can just give tranexamic acid in those cases, okay? And we don't usually do bone marrow unless like you have pancytopenia or
Yeah,
you have like other like lymph nodes or stuff
yes.
like that.
You
But
suspect
usually we
something
don't.
else.
Yeah, we don't usually do bone marrow. We
Okay.
just try to go steroid first and then see how they respond, and then you can do IVIG and then you can give like yeah, and
Biological.
then the last thing is splenectomy.
Yes.
Yeah.
Perfect. Dr. Zainab, you gave it summarized in 2 minutes or less than 2 minutes. Thank you so much. So I have question now. The cut off for transfusion, even with no bleeding,
Yeah,
is
we don't like
even with less than 10, you are not transfusing.
yeah, unless they have sign of like you know, just bleed or something like that, but you don't usually transfuse in ITP. But the
Yeah.
one you said is in other disease, like if the platelet is
Any
less
other
than 10,
disease.
you give transfusion. If less than 20, if they have something like bleeds or any other causes. But in the ITP specifically, we don't usually transfuse unless they have something, you know. In this
No,
case,
Dr. Zainab, for the scenario Dr. Basim told, this patient developed
yeah, I
severe
was just
bleeding.
about to say, for this case, he does have some bruises. She does have, like you said, gum bleed and stuff like this. So for your
Yes.
cases, yeah, you can give platelet just one time maybe, and then start the treatment like with the steroids. Do you?
Yes, exactly. She started with steroid and she
Yeah.
had a trial of IVIG, but she didn't reach to the splenectomy
Yeah.
as a step of management. And unfortunately, she died before that. Yes.
Oh, so she
But
died. She died from the
sorry,
From the
Dr.
ITP.
subarachnoid
Dr.
hemorrhage. Yes.
Zainab, Dr.
It
Zainab,
had hemorrhage. Yes.
Oh, okay. Sorry.
Dr. Zainab,
Yeah.
for this patient to proceed for splenectomy, I think no surgeon will agree to open and put يعني cut in the until he has platelet count is within normal value or at least
No, more than
above
50, I think.
150.
No,
So how you will
So
manage
did
this
it?
case? How you will do? How you will deal with this? You go for the next step, which is splenectomy, and the surgeon said, no, I will not go and cut anything in the incision unless platelet count above 50. What you will do now?
You just usually top them off for the procedure, you know. If you know someone is going even for dental extraction or anything like this, you just let them come during the day of the procedure, give them platelet for the procedure, and then that's it. Is this your
So,
question, is it?
yes, this is one.
Yeah.
So you
You
symptomatic
you top
treatment.
them for the procedure, like any procedure they have, you just stop them from the day of the procedure. Yeah.
Yes, thank you, Dr. Hussein. Yes.
So you will wait until the platelet more than 50. No hurry
Yeah.
for the splenectomy.
Yes.
Okay. Thank you so much, Dr. Zainab. Really, it's a valuable comment from hematology direct to us. We will need you in any hematological case.
No worries. Thank you. Thank you for your help.
Okay, thank you. Any question else before ending the session? Yes, Dr. Wala, given the platelet transfusion, give him the platelet before the procedure. Yes, if less than 30, but less than 10, even without bleeding, induction indication for transfusion. This is what I thought, but Dr. Zainab said in ITP particularly, they are not doing that. So it's exception. Anyway, just give the examiner the guidelines and tell him if there is major bleeding, we have to transfuse. Apart from this, the platelet gonna be distracted by the antibodies. Okay. Invasive bone marrow, as Dr. Zainab said, it's not a mandatory test. It could be helpful if you suspect myelo or lymphoproliferative disorder. If there is something can explain the like constitutional or B symptoms, that time you can suspect cancer, then you can do the sample. Otherwise, or lymph node, for example, otherwise it's not indicated. It's a clinical diagnosis. Again, it's clinical diagnosis. Okay, or diagnosed by exclusion. You exclude everything: autoimmune, vasculitis, viral, liver, hematological condition. Then you suspect the ITP, idiopathic thrombocytopenic pairing. Any question before ending the session? Okay, seems satisfied by all. Thank you, Dr. Mayada, Dr. Mahi, for your cases today. Thank you, everyone, for the attendance. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.